Good morning to all, and thank you for this opportunity to share my thoughts on this topic. It's a beautiful day in Lisbon. I am really in Lisbon, and it's really good to be here with you. Starting this day, it's 8 o'clock in Lisbon. I'm a mother of twins, so it was a busy morning. They are in school now, but it all makes sense. We are in the spiritual topic, and all makes sense. Being here with you today makes all the sense. So I'm sharing some slides, and I'm not providing a lecture, as I'm not teaching anything to you. I'm sharing some thoughts, many questions, and my goal with this presentation is to bring together some questions that I think we do need to speak about, because we've been listening in these 2 days. What is spirituality? What is religion? What are the specificities of the older patient, whether in physical, mental, psychological, social aspects? So my challenge with this presentation is to think with you in many aspects that I do think we need to start discussing as it deserves to be discussed. I will share some slides. I hope you can see now. It's okay? Okay. So, welcome to Portugal. You are in Lisbon, near the sea. It's a sunny day. And if you were all here, we could travel on this beautiful, beautiful, I don't say how to say in English, bands probably. Take the direction to Lisbon, and you will be here near the river. And you would find Renee here. He's here. This is Lisbon. And if you were here, probably we would have a Portuguese cream and a coffee. This is very typical for us. So I invite you to imagine that you are taking a coffee and having this before taking this conversation. And welcome to the Catholic University of Portugal. We are in 4 different cities in Portugal, but I am based in Lisbon. And we should be here today in this auditorium. So imagine that you are seated here in this cozy sofas, listening to this presentation. So welcome to Lisbon. It's a pleasure to be here with you. So I'll start as I said, my thoughts on this topic. And I organized my presentation in 3 main topics. There are, what is being older patient? What is today being an older patient? I don't know if it is the same of 50 years ago. I'm not sure if it is. For sure it's not. I think we need to think about what is spiritual care. And regardless, I'm a nurse, I will do this discussion within a healthcare team dimension, not only as a nurse. And I think we do need to think what's next. What's next? Moving forward, the future. So, what's an older patient? Well, I would say depends on the country. In Brazil, you have an older patient if the patient has more than 60 years old. In Portugal, it's 65. So it depends on the country. But the question is, and the challenge is, in yellow, I have my challenges to you. It is just about the age. It is all just about the age. Is this the only criterion that we should think of? Then we have another situation around the world, a widely situation, that is the oldest old. What do we know about this condition? What do we know about the oldest old? Those who have more than 80, 85 years old. Do we know enough about this life condition to provide the best care we can? Have we, at this moment, do we have enough research to understand the needs of this particular population, the oldest old? I don't know if 50 years ago we would be speaking about the oldest old, but today we do need to think about the oldest old. And this is really challenging for the healthcare system in every country. So we have the idea that the older is living longer, and it is. And that is the problem or not. I don't know if it's a problem, but it's living longer. What challenges in healthcare dynamics, structures, and ethos? Because this calls us to many different aspects in care regarding autonomy, respecting decision-making, respecting all the values and beliefs and all the history that that person has built across the lifespan. So this is the older patient today. It's challenging. It's different from the other years before, probably. And when we look at the World Health Organization, and this is from 2018, but today is still the truth, we know that between 2015 and 2050, the proportion of the world's population over 60 years will nearly double from 12% to 22%. This is really challenging. By 2020, so last year, the number of people aged 60 years and older will outnumber children younger than 5 years. In 2050, 80% of older people will be living in low and middle income countries. And this is bringing a discussion on poverty that is really important to have about poverty. The pace of population aging is much faster than in the past. Yeah, this is true. And all countries face major challenge to ensure that their health and social systems are ready to make the most of this demographic shift. So I brought this here as a screenshot because this is the World Health Organization content. And we do need to look at this and be prepared for the challenges in the future. The older patient, as a thinking in the healthcare dimension, bring this to, well, it may bring others, but mainly these two topics. There is health, there is a core issue in life, and dignity. Health, because when we speak about older patient, we think more in quality of life and well-being. And then these two major concepts also driven to different interventions. So health in older patient is thinking about quality of life and well-being, the level of well-being, the status on well-being. But because we're speaking about older patients, there's the other dimension, there is dignity. They live for a life. What is the dignity of these patients? So when we think about dignity, we are thinking in autonomy, and it's not the physical autonomy, it's not the dependency or not, it's autonomy in decision making, in deciding what they want for their life, even having 80 or 90 years old. And it's about respecting the life narrative and identity. And this is bringing topics that are the core of the ethos and the legis artis to the discussion in healthcare when speaking about older adults. What is being older today? If we have like a metaphor of life, we have the spring, we have summer, we have autumn, we have winter, and the older seem to be in the autumn of a lifespan. Some would be in winter, but the autumn is the metaphor for the elderly. It's that stage that some things are falling, but that's okay because there is future. And I think it's very important to look at these stages and to realize that when we speak about older and in the dimension of healthcare, we can think on illness and clinical status, and older today live longer with more diseases. We think about dependency and what this brings to healthcare systems. We never speak as today about long-term care. Long-term care, what is this? We have more dementia than ever we had, but we also have loneliness, and this pandemic, the COVID pandemic, brought this disclosed this reality. We have so many older people that are alone, living alone, and the poverty. And I think this is a big issue widely. It's the poverty and the elderly. Is looking at the conditions that people are living on. But by the other hand, as we are thinking in religion and spirituality, this is the stage in life that people have time, that people have the lived experience that we can't have before. You need to be on that stage to have. There's no way out. You need to be there to have that time, that meaningful time, and that lived experience. And this makes all the difference when you are a healthcare provider. So this is like a bang. This is not a problem, but this is a huge opportunity to provide spiritual care and to speak about spirituality or religiosity or religion with this patient, as this is the stage for the opportunity to find meaning and purpose in life. And this is the contemplative period of life. So being older today is thinking that the older is in the center of healthcare system, but you also have family and social support, and the healthcare team is embracing all, but the patient is in the center. But what is spiritual care as provided by this healthcare team? Then you have the concepts, multidisciplinarity, holistic, and patient-focused. I repeat, you have the concepts. We need to think, is this what is happening in the healthcare systems? We have different professionals within a team. We have physicians, we have nurses, we have social workers, we have psychologists. Do we work on multidisciplinarity? Having different professionals is the same as working in multidisciplinarity? I'm not sure. That's why I'm bringing this discussion. Let's think about it. The word holistic has never been so frequent in our speeches, in our papers. We need to say holistic care, to provide holistic care. Holistic is used. Let's think about what we do each day. Do I provide holistic care? What is this? And in all my decisions as a healthcare member within the multidisciplinary team, is the patient on the focus? Is a patient-focused intervention, team intervention? Is this the main topic? Is this the main, how do I say, paradigm in health? I'm not sure. I'm asking, what is this 3 topics when we speak in older within healthcare teams? So the question is, what is taking care? Taking care of older patients. I need to know what is taking care. Because if I go to the coffee and ask, please, I want a coffee, the person that gave me a coffee took care of me, of my needs of coffee. Is the same in healthcare services? What is taking care? What is multidisciplinarity? I need to think who I am within the healthcare team and what are my responsibilities. Because I'm a nurse, I'm not a physician, but I need to work with a physician. I'm not a social worker, but I need to work with him or her. But I need to know what are my concrete, specific responsibilities and be engaged with that. Then when thinking in holistic, I need to know what and how is including all dimensions in care. What is this holistic? What is this whole? Is this only a theoretical goal? Is this some kind word and beautiful word to write in the papers? How do I bring this into clinical practice? How do I make this happen? And regarding patient focus, are we ready for this? Sorry about this question, but are we ready for this? For putting patient on the focus? Are healthcare settings ready for this? How often and when do we start from here? In education, in nursing education, in research? Do we start from here? Or this is where we want to get? So this is my question. I told you, I have so many questions. I need to think with you. What is taking care? What is taking care? Is looking first. I need to look. I need to listen. I need to approach. I need to want to be involved. I need to want to be engaged. I need to take responsibility for, I need to take that patient on my shoulders and provide the best answer. I need to provide safety care. And we know that safety, patient care is a big topic today, but we do need to provide safety care and to guarantee the continuity. That is, ou seja, I was speaking in Portuguese, sorry. That is guarantee that even when I'm not in that setting, on that long-term care, the patient is also being cared with quality within this patient safety care. But I also need to move forward. Otherwise, I'll get burnout. I'll get compassion fatigue. I'll get really tired as a healthcare professional, and we do need to move forward and let go. And you know who is the best teacher for this? It's not a textbook. It's not a nursing textbook. It's not a physician textbook. It's the Good Samaritan. Whether you believe or not, whether you're Catholic or not, this is a good metaphor for what is taking care. It's looking, it's approaching, it's taking the same level of the patient, of those who need us. It's taking responsibility. It's taking to the house. It's guaranteeing safety, and is moving forward. And this is the best lesson for what is taking care. So it's supporting in finding meaning in life. If I think about spiritual care, in health or illness condition, because spiritual care is not only for those who are sick or ill, is respecting beliefs and values, and is managing suffering. It's about these three main topics. It's helping people to find the meaning, is respecting their framework of values and beliefs, and is managing suffering. Whether it's decreasing or not, I will help that patient in managing that. I can't say I will stop suffering. Who I am? I don't know. I will help on that management. I will help on that experience of suffering. I'm there for that, to manage, to help in that journey. So we do need some competencies as healthcare providers, whether nurse, physician, social worker, psychologist, gerontologist. We need, I think, these 5 main topics. That is communication, team, working in team, ethics, professional skills, and self. It's who I am in that care. So about communication, I think we need to look at time in a different way, because time has 2 different meanings. It could be chronos, it could be kairos. And if I'm just looking over the chronos, I'm looking at the clock and the seconds and the hours, and I will always say I have no time. We don't have time. 24 hours are not enough for all we have to do. So I think we need to look at time in a different way, and the kairos dimension, that is the meaningful time, regardless the period of time that I'm with a patient. And this makes all the difference. Then we need training. We need to start learning how to communicate. We need to start training how to approach the patient, how to listen. Because now I'm speaking as a nurse, sometimes we are focused on teaching students what to say, what to do. We need to speak, to train also our students to how to keep in silence, how to listen, quiet, stay quiet, just listen. And this is the most challenging thing to do. Listening is really challenging. We need to train these skills. And we need to provide as nurse, as physician, we need to provide some atmosphere that sometimes is not there in the healthcare settings, for privacy, for silence. There is really important to provide spiritual care. We won't speak about such a deep, intimate, and personal topic if you not have this privacy or silence, or feeling that you can speak. So we need this basic, I would say, conditions to provide spiritual care. So about the team, the big topic who is responsible for spiritual care? And then we are, it's me, it's the nurse, it's physician, it's the chaplain. No, it's social worker. No, it's the psychologist. And we are on this discussion. Enough. We all are responsible for providing spiritual care. But as a nurse, I know that I'm responsible to provide spiritual care in my domain. And we do need to stop asking who is responsible for. We all are in my domain of responsibility and duty. We all are responsible for providing spiritual care. Then the discussion should be only one responsible. We need to have one. And no, we are all responsible for spiritual care if we know how to work in multidisciplinarity. But we also need to know which resources are available for providing spiritual care, whether they are clinical records, assessment tools, healthcare providers, which resources are there to help us on this spiritual care. And we need also to be aware of each one competencies and responsibilities on that. This is multidisciplinarity composed of different disciplines. So we all need to know my own responsibility within this global perspective. How prepared is the team? Our research in palliative care teams in Portugal found that people do know that this is an important topic, but when we ask about the resources, no resources, about education, no education, about specifically what they do, it's like there's nothing that we can hold and analyze. And there's another topic that I think it's really important to start thinking about, that is about workplace spirituality. Healthcare providers also need to be cared for. We need to develop this, I don't know if this is the best concept, but spiritual leadership in healthcare teams. People need to be also cared and feel cared for. So the next topic is ethics. And when caring for spiritual care for older patients, we can't move from here. We need to be aware of culture sensitive care, dignity preserving care. We need to discuss who is prepared for, because the patient deserves the best care, the best healthcare provider to attend the needs. Then, in what concerns ethics, we must be aware that some cultural and religious values may lead healthcare professionals also to feel some moral distress or some moral discomfort on dealing with these topics. Then we need to define boundaries, but again, we need to know our duties, our specific duties and responsibilities to decrease this sense of moral distress. In what concerns professional competencies, we do need to remember that research is very clear on this, spiritual development is related to better spiritual care. We do know this. We know that those, we know that those that are spiritual developed may provide better spiritual care. I don't know if the word better is the best word, but they are they are more sensitive to assess spiritual needs, at least. But can I expect from all healthcare providers to have this spiritual experience? Is this correct to ask all them to have it? It's not correct. Maybe we cannot expect that from all, and we need to know that those who are who have this spiritual experience and engagement would be more sensitive to spiritual care. We do need to consider that there is a lack of training, period. There is a lack of training, still a lack of training. And we need to move forward the assessment to the intervention, because we all know we have assessment tools, we have scales, we have questionnaires, we know how to approach, we have FICA, we have so many instruments and resources. We need to move forward. We need to go. We do need to implement spiritual care. Then there is a reductionist approach to religion still in some contexts. This is true. Spirituality is almost religion. But we do know that spiritual distress in cancer patients, for example, the prevalence is 30 to 45%. This is too much suffering. We do need to regard this. We cannot ignore this. Then there is another topic that I would like to bring to discussion, that is the subjectivity versus the assessment tools, because the assessment tools that we have, they are good for research. Are they friendly user in clinical practice? Because there are 20 topics, 20 items, they are too long to apply in clinical practice. We need also to think about this. We need to develop shorter assessment tools. We need to develop models for multidisciplinary spiritual care based on evidence. And I think that is important too, that healthcare professionals feel that they are also cared as healthcare staff. About the self, I think that those who are interested in providing spiritual care need to be aware and prepared for transformation, and need to be aware that they are the best resource as person to spiritual care, because they are providing support on coping with suffering and existential issues. But at the same time, they also need to feel free to express their own beliefs and values. And this is about the self, the person that I am within the healthcare team, within the care. So what is the specificity when thinking about older patients? It's the reality. It's all about demographics. It's a main healthcare challenge. And we do need to be prepared for. How do we need? Among funding, guidance, organization, structures, I think there are two things that are foundational on this topic. That is research and education. I selected these two. Research to develop more evidence, to inform practice, and to develop knowledge. And education to help healthcare staff, whether nurses, physicians, wherever, to develop competencies, skills, knowledge, to provide spiritual care within multidisciplinary and patient-centered approach. I think this is the two main challenges in the future. About education, I'm bringing you an example. It was published these days, a matrix for education of nurses and midwives. There are four main competencies, and I invite you to read this. That is the result of a big project that was funded by Erasmus, and provide some guidance on how, when to implement spirituality and spiritual care in the education of nurses and midwives. I think this is really interesting, and I'm bringing this today for you to look over and to analyze, as this is really an update information. Then in research, I'm in a few minutes sharing the experience of my research group. There is Spirit in Health. It's a research project of the Center for Interdisciplinary Research in Health at the Catholic University of Portugal. This is a group mainly composed of PhD students, and they are here today, and they are presenting posters and research. And this is a group mainly composed of PhD students and researchers, counting on Portuguese, multidisciplinary Portuguese researchers, but also international networking. We've been working with many researchers from other countries, depending on the topic, depending on the research method. We look after this collaboration, and it has been a really good experience. We are focused on the study of spirituality, and with all that this includes. So spirituality and health, this is the main two topics. We are a group studying spirituality and health, hugging all patients as unique in mind, in heart, from the beginning to the end of life. And this is our group, Spirit in Health, our logo. Then you know, how do we get this logo? This is the meaning of our logo. And we have the Facebook, we have social media. Please follow our research, spiritualinhealth.portugal. And we have 5 main dimensions on research. That is basic. It's A-E-I-O-U. So it's really basic. We have the assessment and diagnosis dimension. And here we develop concepts like spiritual comfort, spiritual distress, spiritual being, resilience, dignity, spiritual coping, all the concepts that are related to the spiritual domain. And we also validate nursing diagnosis. What is this in a few words? It's trying to, based on research, find which are the most sensitive, predictive, and specific clinical indicators that patients have that may help us on diagnosing spiritual distress, impaired spiritual being. We have so many diagnoses that we do need to improve on evidence. We don't have so much evidence to inform clinical practice. So this is the A dimension. Then the E, it's education and theory. We have studies on undergraduate nursing programs and spirituality in curricula. And we have some research in developing middle range theories regarding spirituality in nursing in this case, but also in care. I didn't bring the papers that we have publishing. I'm just presenting the project. We are working on interventions. We have Tiago Casaleiro presenting one poster today. He's developing an intervention related to spiritual coping in care, those who care for mental health patients. We are also have a PhD student developing a promotion of forgiveness in palliative care. In the outcomes, we are trying to have RCTs to study the effect of the interventions in some outcomes for example, prayer, intercessory prayer in breast cancer patients. And there's I think it's an innovative dimension in our project that is using resources and management. We also have a PhD student working on trying to find the relation between spiritual being and the provision of spiritual care, but in the perspective of the spiritual leadership. Those who feel cared for the managers provide better care, better spiritual care. So we are also in this domain. This is just a shot of our project, but we need to move forward from the understanding the concept and the lack of education to implementing and to training. I think this is really important. And you see here, for older patients and for all, this is not for older patients. So what do we need? And I'm just finishing. We need networking. We can't do anything alone anymore. There's no place for that. There's no space for that. We need networking within the team, within the institutions, between the institutions, and between countries. And this is helpful for all, but particularly helpful for patients. Getting the best evidence, getting best research, getting best studies, just for best care. We need education and training, whether it's undergraduate or postgraduate education. We need strategic plans, sorry about this, at healthcare institutions. And we do need quality outputs in monitoring the healthcare provision. That may include also spirituality. What indicators are there to analyze spiritual care in the quality plan? And I'm not sure, not every institutions have it. Yesterday we listened to a Brazilian researcher that speak about that, and it was really important. And we do need to move forward into this. And we know what's next. Again, research. We need to put spirituality in the agenda. When we apply for funding, we know the difficulty that is to say that spirituality is also a healthcare issue. It's a priority, and we need to challenge new research and new designs. And again, the funding. I think this is really important because I feel uncomfortable to always need to justify that spirituality is also a health topic. I don't need to be evaluated on my research project by theology or philosophy or sociology. I would like to be by a healthcare expert panel. Do you know what I mean? And this is really challenging. And we need to think about this. And sorry for my, I think I am seated, but this is really annoying because we need always to say, this is a healthcare topic. Hello, this is a healthcare topic. When we speak about holistic care, we are speaking about this. So please stop giving my projects to a panel of theology or philosophy. This is a healthcare topic. And this is difficult to get funding. And I would like to listen more about your experience. And at least we need to accept time. Otherwise, we'll get hungry, as I am now when speaking about funding. But we do need to accept time. We need to accept limitations. We need to accept that this is a challenging topic on education, on research, on practice. It's all about accepting and keep going. It's accepting, keep going, and let go all difficulties. Let go all difficulties. And spirituality and religion is part of healthcare. If not, then all interaction between patient and healthcare provider will be as delivering a regular task and not considering the most unique, deep, challenging, and valuable dimension of life and health. And at the end, taking care of older patients, considering religiosity and spirituality, it's all about considering the wrinkles and what all those wrinkles mean. It's all about respecting the value of the wrinkles. It's like a story written in the skin that the healthcare providers need to be aware of. Thank you so much for your attention to my questions, and I would like to listen to you.
Yeah, thank you, Silvia, for your presentation, for your very clear and passionate also presentation.
I hope you understand me as I speak in English.
Yeah, you asked many questions, but maybe there are questions from the participants. So we have 5 minutes left for questions. Are there any questions? Just unmute the microphone.
It's a great presentation, wonderful, particularly the clear stance that this is a nursing topic. Of course, we do know that team spirit would be wonderful, but we all see the problem. So it's a good idea to say, I'm as a nurse, I try to develop our profession. It's wonderful. But nevertheless, how do you see chances that the interaction with the other professions which are still there, how could it work, effectively work? Because even in our country, even when we say we have nursing studying at university, we do know that theory is much more beautiful than concrete life.
That's true. That's why I asked. It's just a theoretical goal. Yeah, sometimes it's theory. Well, I can say that our research group is really interested in transferring all that theoretical knowledge into practice. We are working with the Portuguese Nurses Council. I think it's the translation, Portuguese Nurses Council. We are working on a guidance, specific guidance for spiritual care, nursing spiritual care. And this is just a way of helping and supporting nurses in how to assess the spiritual needs, how to diagnose, what resources are there for help in this diagnosis, how to provide, which interventions are these, and this is a specific guidance. Then we need to move forward to education. And I think that we've been doing so much at this time that we need to, accept time. We can't go and say, okay, this is important, let's do. I think we need to work on evidence. That's what we've been doing. We know which are the spiritual needs of cancer patients, for example. Why not to start with cancer patient? That's okay. We just need to start. We do know what is for a nurse to say that a patient is in spiritual distress. We know that those who are expressing suffering, and that suffering is related to lack of meaning in life, these two things should call the nurse to, okay, this may be spiritual distress. We do need to have this clinical reasoning concerning spirituality. So it's challenging, isn't it? It's really challenging, but I think it's not a good thing to want a rapid, and it's not good to want to have it tomorrow. we need to do it having evidence and doing step by step with knowing what are we doing. I think that's better than having things and then just you don't have.
Yeah, maybe a last question. We have time for a last question.
Hi, Silvia, I'm from China, and your presentation is really wonderful. How can I say? In China, it's, the patients are suffering, and if nursing can express, use the research evidence to show how nurses patients are suffering without spiritual care. I think it's a very good start to think we do the research from this way. And also, I totally agree that we need to know what we are doing. How can I say? For the funding, it's difficult in here, but how can I say? From funding reply, I think I have some ideas. In China, we cannot mention about the spiritual care or spirituality, but we can apply for the elderly care. And normally, if I involve multiple disciplinary team member, and when I give the presentation to the university multiple disciplinary researchers, they are really interested about this area. But everybody said, no, don't say it, just do it. We just do it, whatever we needed to do. And as we get together evidence, then we can provide for the public. Yeah, if it is possible, we can collaboration together.
For sure.
For the research.
Okay, thank you for your comment. Thank you. You know, we are just finishing a study with undergraduate nursing students. Just 1 minute, and we they were confronted with 4 different scenarios of patients asking them to pray with them or for them. It makes part of the scenarios. And students do expect teachers and nurses on clinical placements to support them on that. They do want. So it's interesting to look at the results. And when confronted with different beliefs and values from their own beliefs, students say they are comfortable just to be there, present near the patient. That's why I said that we need to teach students to just be quiet and to be there, to be. It's not just be physically. We need to help students on that. I think this is really interesting. But thank you for your comment. And I'm more than happy. I didn't let my email, but I think you can have my email by the organizing committee, and I'm totally happy. Okay, I'm totally happy to share our research. I used to say I'm blessed because I have good PhD students. They are here, Rita, Helga, Tiago. So this is teamwork. I'm just representing them.
Yeah, it is. Thank you. Very encouragement, because it is very without people talking together, and nursing seems. We need working together to like in my country, I could not find the people talk about how to do the research studies, and even my students was encouraged by me, but as quite sensitive, because if a student doing spiritual care, they cannot graduate. so that's the problem. So I do by myself. So I don't involve the students.